Hello, and welcome to the Scoliosis Dialogues, the official podcast of the Scoliosis Research Society. I'm Stephanie Ihnow from the University of Florida and your host for today's podcast. I'm honored to have the paper and poster award winners from this year's Scoliosis Research Society annual meeting that took place in Charlotte, North Carolina. I'm joined today by four fantastic researchers: Dr. Michelle Wellborn from Shriners Children's in Portland, Dr. Zhang from Kunming in China, Dr. Melanie Boyer, a skeletal biologist from the University of Missouri Columbia, and Dr. Amy McIntosh from Texas Scottish Rite Hospital in Dallas, Texas. We'll be diving into their fascinating research and hearing the stories behind their discoveries. First, we will hear from Dr. Michelle Wellborn, who received the John H. Moe Award for Best Basic Science and Translational Research Poster this year for her work titled Collagen X Biomarker is Predictive of Growth Cessation in Idiopathic Scoliosis. So congratulations, Dr. Wellborn, on your amazing work on this project. I know how much this project has meant to you over the years, and it's really exciting to see the incredible outcomes of your hard work. Can you start by telling us a little bit about yourself and your journey with this project?
Great. Thank you so much for having me today, Stephanie. This has been a long time coming, and in part because children grow slowly. And so each clinical data point takes 6 months to a year to obtain. And we're about 8 years into this study, and I suspect that I'll probably continue it through the rest of my career. However, it's been a really wonderful journey. And so really to start, this began long before me. It started in the 1980s with one of my partners, Mike Sussman, who first delineated the components of the growth plate. And then another one of my partners, William Horton, who is a geneticist, who really then understood the different components of that. And in the early 2000s, they were able to develop a antigen antibody reagent that were much more stable than what we'd looked at before. And it was only with the advent of these new, more stable reagents that we were able to start doing these tests in a reliable fashion. So where we are now is basically collagen 10 is in the growth plate. It happens actually anywhere in the body where you have a cartilaginous model of growth. So this is any time where soft bone is made into hard bone. So that's the type of growth that we have in the physis. It's the type of growth that we have in fracture healing. And so there's a number of different adjunct studies on this. And so what we can do, though, is measure that degradation product of collagen 10. And that degradation product can be seen in the blood. And so now that we have these new reagents, we're able to test this and not do it instantaneously. So it's not something that has to be done in the room with the patient, which is absolutely not feasible. It's something that can be done in a delayed fashion, which then makes this feasible for research and then hopefully ultimately for clinical studies as well.
That's great. Your poster concluded that it doesn't sound like there's one great measure of growth cessation to guide us to stop bracing or, counsel patients on possible progression of scoliosis. Though it does sound like the collagen biomarker did show the most promise as a single measure. How do you use that information in your practice?
Yeah, so when we think about cessation of growth, we probably all have had different criterias over our career. I know that when I first started in practice, people were typically stopping bracing at RISR 4 because we didn't think that there was a lot of meaningful growth. But then we started having papers coming out showing that upwards of 50% of kids were progressing. And maybe that doesn't matter if the curve's 20 degrees, but if the curve's 30, 40, or 50 degrees, that probably does matter. And so people started using more and more criteria, but a lot of those studies were using either growth or radiographic criteria, but they weren't using both. And so what we looked at in this study was specifically radiographic criteria. We looked at growth and we looked at the biologic criteria. And essentially what we found was that RISR 4, the preponderance of kids are still growing and still having meaningful growth. And so for those kids, we're making sure that there is no progression. That's probably not the appropriate time frame for cessation of bracing. That if instead you used, and again, similarly, Sanders 7A, preponderance of kids were still growing. And while that growth is slower, it was enough that we were seeing a large component of the kids still progressing. Whereas if we switch that criteria to less than 1 centimeter in a year. So measurement error for height is 1 centimeter. So 1 centimeter in 6 months theoretically could have been cessation of growth. However, when we used that, we still saw that 33% of kids were still growing. If we did 1 centimeter in a year, then that number dropped down dramatically. So if you're going to use just anthropometrics, 1 centimeter in a year. If you're going to use a radiographic criteria, you really needed to use 7B and probably RISR 5 as well. The challenge there is that you may well already be done. And so you're probably going to brace some of those kids too long. But if you're using both of those together, the rate of kids that were growing dropped down to about 20% of kids had some degree of progression of their curve, but they didn't have any meaningful growth. So that point, we're probably answering that question of, was it that they were still growing, or was it some relaxation of the curve or inherent properties of the curve?
So that's great. That really helps of us that don't have access to this, this collagen biomarker test really determine kind of and counsel patients on when to stop bracing. So how do you bring in the collagen biomarker? Do you use that in conjunction with all these measures? I mean, do you get it on all your patients? I mean, it's not accessible to a lot of us. Will it ever become available to the general population of surgeons?
Yeah, so great question. So I'm actually blinded to it. Because what we don't want is for my patient's outcomes to change, because it's really important that we are looking at those radiographic criteria, the growth criteria that are accessible to everybody. So at this point, I am not using it clinically. However, when we did look at it and we saw that the patient's biomarkers had dropped below 4 nanograms per deciliter, at that point, they had achieved cessation of growth. So if I were to use this clinically, what basically it would mean is that instead of, say, waiting till that next clinical time point, which could be 6 months or a year from now, depending upon when they come visit me, if their growth dropped or their biomarker dropped below that level, I could safely tell them by phone, hey, you can stop wearing your brace now. And that is important because bracing, as much as I'm a big brace advocate, there are clinical ramifications in terms of weakening the core muscles. There's psychological ramifications, sleep impact, all of those things. And so prolonged bracing is probably not great. In terms of access clinically, so it's been a long time coming. We actually recently changed our reagents, and that was actually a 2-year process to get new and updated reagents, but they're actually better now because we went back and tested our old specimens. So we've got new reagents that we will be able to have long-term and better reagents. And we additionally are getting our labs CLIA certified. And for anybody that's gone through the CLIA certification process, it is long and arduous and expensive. And so once that's the lab has been CLIA certified, at that point we'll be able to apply for FDA approval for a diagnostic test. There's different levels of criteria for different types of testing, and so this particular one would probably fall into that category. And I'm a surgeon, so I way underestimate my operative time. I also way underestimate the amount of time that it's going to take for me to get something to market. I keep thinking another couple years, but realistically, we're probably looking in the 2 to 5 year range. But hopefully at that point, you'll be able to have your patients just send in a little finger prick on a piece of filter paper, and we could say, nope, you're still growing, or you've stopped, and maybe change the time frame by months.
That really puts a different element to kind of telemedicine and virtual visits, to be honest, to not even need to see them and get an x-ray. So that's really awesome. If you just want to wrap up your kind of study in 1 or 2 sentences and the real impact of the study and your future directions, if take a second to do that, please.
Yeah. So I think my big clinical question going into this was, when is it the right time to stop bracing? And the people that were progressing, was it because they were still growing? Was it because they had some property of the curve that was continuing to make it progress? And the reality is the answer is both. So if you're not concerned about a small amount of progression and the patient is struggling, stopping at a RISR 4 or standard 7A is probably reasonable. But if you have a high degree of concern that any progression of that curve would impact them clinically, then waiting until patients have less than 1 centimeter of growth over a year, they are a RISR 5 and a standard 7B is going to be your best bet for preventing short-term and long-term progression of that curvature. And overall, I think just continuing to ask questions and better understand the why of why these things are happening can only help all of us to be better at what we do.
Great. Thank you so much. It's awesome work that I think really helps a lot of us with our clinical decision making and our, eventually our, especially our patients. So appreciate it.
Stephanie.
Okay, next we're going to switch gears and hear from Dr. Melanie Boyer, who received the Louis A. Goldstein Award for Best Clinical Research Poster for her work titled Growth Modulation Does Not Improve 3D Axial Rotation After VBT, a 3D multi-center analysis. So Dr. Boyer, welcome again and congratulations on your award and the findings of this poster. Can you start by telling us a little bit about yourself and how you became interested in this topic?
Sure. Thanks, Stephanie, for having me. And thanks to SRS for giving me the opportunity to present some of our data and for this awesome award. I'm honored, honestly. I can't believe that some of the stuff that we're doing is this impactful. So it's really great to be here. I am a skeletal biologist, so I have a PhD. I am not a surgeon. I do research only, but I work closely with a lot of surgeons. And this project specifically was in partnership with the HARMS study group. So it's this big collaborative group of surgeons who collect data all independently at their institutions and then put it into a database. And then that gives me the opportunity to query some of that data and ask some scientific questions that hopefully will improve clinical outcomes in the treatment of their patients in the future. So they gave me the opportunity to look at some of their data, which was great. And this is kind of the culmination of a lot of work from multiple surgeons across the US and internationally, actually, on patients who were treated with vertebral body tethering, which is a new, innovative, non-fusion treatment option for kids who have scoliosis with growth remaining.
That's awesome. And I think the main finding that I kind of took away from this was that your study found that patients had significant improvement in their clinical angle of trunk rotation from pre-op to post-op, but the radiographic 3D modeling using the stereos did not show that. Can you kind of explain how you were using the 3D modeling? Were you looking at each vertebral body individually, more globally? And why do you think this was the case, that there was a difference between clinical and radiographic findings?
Yeah, excellent question. So the way that we do the 3D modeling is we take biplanar x-rays in a new x-ray machine called an EOS. And so it is like a slot scanner. And so it allows us to link the posterior, anterior, and the lateral radiograph in one. And so from that, we can build 3D models. And so what we did for this project is we specifically looked at the apex of the curve, so where it's the most deformed. We looked at that vertebra and then looked in the patient plane, so aligned to what would be a neutral axis for the patient. We looked at how rotated that individual vertebra was at the apex, because that's where, in theory, the majority of the deformity should be. And we know that we know that scoliosis is both like coronal deformity, but also an axial deformity. And there's been a lot of work that has looked at axial or coronal plane correction, but not as much with the axial plane. So this was a very specific measurement. There is some measurement error associated with that, just the same as with clinical measures. So when we use the scoliometer and we look at kind of how much of a rib hump do patients have, there's error in that as well. But that's an easy clinical measurement, and the 3D reconstructions take a lot of time. They're very research intensive. And not necessarily practical. So we kind of wanted to pair the two to see if we could see similar findings. And although we didn't reach statistical significance in the 3D changes, we did see similar correction, you would say, in the clinical measurements and the axial ones. The difference is just that the measurement error is higher. But in general, kids can expect 3 to 5 degrees of axial rotation correction after VBT. And it's a little bit different if kids actually modulate their deformity. But the results are similar, just not statistically significant. But I think clinically, they're still meaningful.
Do you remember kind of what the mean ATR was, or degree of axial rotation was pre-op for the patients, and like kind of what the range was? I think it's useful to tell patients a percentage, like you're going to get 50% better. I think they understand that more than kind of 3 to 5 degrees. So just curious if you had that information that we can use.
Yeah, good question. So we didn't look at the percentage specifically, but in general, kids tended to be somewhere between 10 and 15 degrees of 3D rotation that we were seeing. And then that decreased by 3 to 5-ish degrees. So I think you could say, somewhere between 30 and 40% correction was achieved in most of the kids.
Yeah, I think that's really helpful with the patients and
Yeah, it
showing.
definitely gets better. And I don't know what other surgeons have been telling their patients, but at least here in the surgeon that I work with, we don't promise any axial correction for kids who get VBT. We say if your rib hump or your cosmesis is something that you're really worried about, we would recommend a fusion instead. And I think that these data now show that we can get some of that correction. So if you're okay with just a little bit, we could probably see that with VBT.
Absolutely. I mean, I think that's really important and that's really awesome that we have some real concrete, numbers to show that. So you also found that, that as you said, that the change in axial rotation was not dependent on whether the patient growth modulated or not. So it sounds like our growth modulation is really just happening in the coronal plane. Do you have any insight as to why you didn't see a difference?
Yeah, that's a really good point. So I think the one thing to point out is that the sample size was relatively small. So we required patients to have these special x-rays both preoperatively at first erect, so within that like 0 to 6 week time point from surgery, and then also at 2 years. So the number of kids was really low. And then the number of kids who actually modulated was even lower. So only 18 kids in our sample corrected their coronal plane deformity enough. And so really, I think we're underpowered to really show the statistical differences in the axial plane. I will say we have kind of followed this study up with a comparison to the fusion cohort, and we were able to capture a couple more patients who modulated, and we did actually see significant differences in that subset. So I think modulation is a key component, and I think as the indications for VBT are becoming more narrow and more growth minded, I think we will start to see more changes in kids who modulate versus those who don't. But right now, kind of based on these prelim data in some smaller numbers, we can't say it definitively, but I think it is trending in that direction. And then I think the other thing to remember is that, the success for VBT is the target is moving. It depends on who you ask. Every patient has a different outcome that they're looking for. And so we know that coronal plane correction is a really important component to maintaining their curve at that level past maturity and as they age. So the modulation piece is absolutely relevant for that. Kids who modulated and corrected their coronal plane did better in the long term than kids who didn't. Now, whether we're correcting all of the axial deformity, it's hard to say. But we do get the most, I would say, on first erect. So it's actually happening in the operating room, and less of it is happening with growth.
Yeah, I always talk about defining success, right? Because
Yep.
everybody has their own idea of what success is. So it's really important at the beginning when you're having these conversations.
Yes,
Um,
100%.
so that kind of takes us to, I think you kind of alluded to what some of the next steps are for this project, really kind of probably increasing your numbers and getting some more power behind it to see if we can find some real differences. But if you want to just kind of talk about your future directions and takeaways.
Yeah, sure. So I think the biggest thing is, ultimately, I don't think most people who are doing VBT are advocating that it is a replacement for posterior spinal fusion. I think it is an alternative treatment option in a subgroup of patients. But really, the question that reviewers and I think our surgeon community and patient community are asking is, how does this compare directly to a fusion? So moving this study into making a matched cohort comparison that's also multi-center for kids who got a fusion, who had very similar curves, same instrumented levels, and seeing how that directly compares when you can do derotational maneuvers with a posterior spinal fusion and pedicle screws versus kind of this anterior lateral approach that you get with VBT. So kind of doing that head-to-head comparison, increasing the numbers, and then just seeing what happens when we start picking more of the right patients who are going to modulate. And then I think just the overall take homes from what we've seen so far is that even though we didn't reach statistical significance in the axial plane for the 3D rotation piece of it, I do think that patients who modulate are going to have better outcomes, both in the coronal plane and in the axial plane. And that is true both clinically and for the 3D reconstructions. And they should expect somewhere between 3 to 5 degrees of correction if you see modulation.
Yeah, I think it's also important to, like, as you alluded to, defining clinical versus statistical significance, right? Like
Yes.
clinically, they might notice a difference even if it's not statistically significant. So,
Right, and the variation is wide. I'll be honest, the spread was quite significant, and that makes sense, right? But if you, because every kid is different, every curve is different, but if you tell a kid that like we're going to be able to reduce your rib hump by 5 degrees, I think for a lot of patients that is important, and especially as Michelle said, for mental health and things like that, I think self-image. I think that is an important component. And whether it's statistically significant or not, if they're happy, that's what matters.
absolutely. Thank you so much. It was a great abstract to read. I appreciate it.
No problem. Thank you for the opportunity.
Okay, next we have Dr. Zhang. Congratulations on receiving the Hibbs Award for Basic Science Translational Research Paper for your work on spinal growth regulation by interfering chondrocyte function in growth plates as a potential treating method for scoliosis, a preliminary study in piglets. This was a really exciting study looking at using medications to induce or block chondrocyte apoptosis to either produce or prevent progression of scoliosis in piglets. Can you take a moment to tell us about yourself and your background?
Okay, thank you for having me, Stephanie. And it's 11 o'clock at night in China, so I'm a little tired, but I was happy to be welcomed to talk about my research. And I come from China, and there is a lot of spine surgeons in China who are looking forward to win the Hibbs Award for the SRS. So I'm really happy to win this award. It's the honor of a lifetime. So at the beginning, why do we choose to perform the drug injection to treat the scoliosis occurred in the growing spine? At first, why did this idea come to me? The idea why did this idea come to me is because in our clinical practice there are nearly 30 to 50 US patients will come to our center every year to perform the surgery. And during the recovery, and we found some of the patients will underwent the metal implantation related complications such as the tip wood infection and the rod breakage or something like that, and it will. And most of the patients are the child. They will this applying back to the operation room will cause fear to this child. So that that makes me think, how can we avoid the use of metal implantation? This may reduce the complications related to the metal implantation. So that is the reason why we choose this study. And why do we choose the aldosterone is because there is a lot of drug that can induce the chondrocyte, induce the apoptosis of the chondrocytes in our growth plate. But why do we choose the aldosterone is because aldosterone is a small molecule compound which has stable chemical properties. So it can penetrate through the end plate because in this study we choose to inject the drug into the intervertebral discs, and the drug will penetrate through the end plate and act on the growth plate. So if we choose a large molecule compound, it cannot penetrate through this. So that is why we choose this drug.
How did you isolate the injection to just one side if you say that it kind of does distribute itself once you inject it?
Oh, that's a good one. That's a good question. And because the biggest challenge we've ever met in this study is how can we make sure the drug just act on the one side of the growth plate, since the growth plate is in the piglets we choose to perform this experiment. The piglets of every vertebra is just the diameter of the growth plate is 2 centimeters. It's very small, and the intervertebral disc is also small. It only can contain small dose of the aldosterone. So how to make sure the drug can reach effective concentration and at the same time can also act on one side of the growth plate is very difficult. So that's why because our team previously used the temperature sensitive type of gel, the pulmoxamer, to perform the in situ drug injection. And so we just give it a shot and we use the pulmoxamer to load the aldosterone. And we then inject it in one side of the growth plate. The pulmoxamer is fluid when the temperature is under 40 degree, the 4 degree, 4 centigrade. I'm sorry. When the temperature is under 4 centigrade, the pulmoxamer is fluid, and when the temperature is our body temperature, the 37 centigrade, the pulmoxamer will quickly transformed into the semi-solid. So if we hold the pulmoxamer under the 4 centigrade and we quickly inject it into our body, and we will quickly transform into a semi-solid, and the semi-solid will confine the drug to one side of the growth plate and make sure it just act on one side of the growth plate. And that's what we do.
Very neat. So I guess the real question, right, from this study is where can we go with this? How can we use this clinically eventually? I know we're probably pretty far away from, using this in humans. But what are kind of some of your thoughts on where you guys are planning on going with this project?
So uh, that is a good question because our team also think about this. Uh, it's just for now, it's just experimental study, and this study itself also have these advantages because the drug we choose not only just act on the growth plate alone, because at the same time it will cause some side effect. It will also induce cell apoptosis in the bony tissue, in the adjacent tissue, such as the intervertebral discs, the nuclear pulposis, something like that. And so before we use such method in our clinical practice, we will try to find out a better drug. The drug will more accurately just act on the growth plate itself. And luckily, there is one specific drug we can use, but I can't tell you today. And we should also do the experimental study before we can apply it in our clinical practices. So if we can get satisfied results from our next experimental study, we'll try to consider how we can be transformed into our study, transformed into the clinical practice. It still has a long way to go.
Yes, I'm sure. So any final thoughts on your project or summarize kind of the findings for everybody? Dr. Zhang? Do you have any
Oh,
final thoughts on your project or want to give any final thoughts to everybody about your project and all the findings?
I mean, for me, for my team, the results of our study is very meaningful because it gives us a solution to avoid the use of meta implantation. But this conclusion is just theoretically. It's just like I said before, it still has a long way to go. But we have faith in it, and we will try to find out the better solution. And I hope in the future our study results can be applied in our clinical practice. Thank you.
Yeah, that'd be absolutely amazing. Okay, next I have Dr. Amy McIntosh from Texas Scottish Rite Hospital in Dallas, Texas. She was the recipient of the Hibbs Award for the best clinical research paper for her work titled Wait to Operate. Surgery demonstrated no pulmonary benefit compared to non-operative treatment in EOS patients. So Dr. McIntosh, welcome and congratulations on your award and the findings of this paper. Can you start by telling us a little bit about yourself?
Oh, sure. Well, first, thanks for having me. I'm a pediatric orthopedic surgeon with a emphasis in scoliosis, particularly early onset scoliosis, and I work at Texas Scottish Rite in Dallas, Texas.
Excellent. Can you tell us a little bit about your exciting study and what was the most significant point that you took away from it?
Well, first of all, I just want to thank everybody for allowing me to present the work, and then it was a surprise to win the Hibbs Award. Oftentimes, I feel like PEDS papers have a harder time just because we don't nearly have the patient volumes that some of the adult papers have. So obviously, I think this maybe struck a chord with the audience. And I think it was because it was focused on patients that have early onset scoliosis. And so I feel like that's a very, pure condition that we're all trying our best to treat. And the other emphasis was of the paper was focusing on their, pulmonary function and pulmonary function tests. Um, and with a specific emphasis on trying to treat the dreaded thoracic insufficiency. So I think for all those reasons, maybe uh, this paper caught the interest of the audience. But basically, what we looked at were two cohorts of patients. All patients had early onset scoliosis. We broke them up into their categories of idiopathic, congenital, neuromuscular, and syndromic. And then we looked at their preoperative PFTs, so pulmonary function prior to any surgical intervention, and then postoperative PFTs at least 2 years post-op. And then we compared them to a similar cohort of patients that were matched based on their etiology, so whether it was idiopathic, congenital, neuromuscular, or syndromic, and just looked at what those patients that didn't have surgery, what their pulmonary function tests looked like. And then we did a third, it was kind of convoluted, but a third matching where we tried to then control also based on Cobb angles. So trying to, compare the biggest apple to the biggest apple. But basically, it was kind of sad, but also, I think, a good message. Operating on patients with early onset scoliosis did not improve their pulmonary function. Um, Basically, patients that didn't have surgery, they were able to maintain their pulmonary function over a period of time, whereas patients that had surgical intervention in the form of early onset scoliosis surgery, sadly, their pulmonary function declined, regardless of our surgical intervention. So I think that was like eye-opening because all these patients come to see us because they're saying, I want to have spine surgery so that I can maintain my pulmonary function. or at least they often say I want to improve my pulmonary function. But this study showed that surgical intervention, unfortunately, did not improve pulmonary function, and sadly, patients that had surgery had declining pulmonary function when we compared them to a group of patients that didn't have surgical intervention.
So when you talked about matching by Cobb angle with the
Mhm.
surgical versus the non-surgical, you matched by the corrected Cobb angle or their pre-op Cobb angle?
Preoperative, yeah.
Okay, and then their post-operative Cobb angle should have been, so you had pre-op Cobb angle, so you had some non-operative kids with pretty large curves, or what was kind of the
Yeah,
average?
like the average, I think, they weren't the crazy ones when we did the matching, but the preoperative Cobb angles were like in the mid to upper 60s, which, is a very reasonable size surgical curve. And then it was interesting, even though the non-operative patients still had the bigger curves post-operatively because they had no intervention, the post-operative patients, their curves were smaller, the Cobb angles were smaller, but their PFTs still were worse.
That's
Uh,
really interesting because we do this to hopefully improve or at least not make worse, right? And we think that Cobb does, correlate
does
with
not.
outcomes. Did you
And
look at
and I
sagittal?
think that's because a lot of the early onset scoliosis surgery, we don't control the apex, right? We do growing surgery and we span the apex. And so a lot of these surgeries were traditional growing rods, a few magic rods. So if you're not controlling the apex and, you're growing, technically maybe their thoracic height is getting longer, but their apex is still, translating into the hemithorax. That is, I think, a possible reason why the pulmonary function declined. Because a lot of growing surgery we do across the world and in the United States does not involve apical control.
Yes, agree. But the title of your paper, Weight to Operate, I think it meant two things to me. We just discussed that surgery may not improve pulmonary function, but then you looked at your surgery cohort and you found
Mm-hmm.
that delaying surgery and doing a definitive fusion may be more beneficial for their pulmonary function than doing growth friendly constructs. So I think the Weight to Operate is really brings up the question whether we should operate. But if we do make that decision, maybe we should wait and do definitive fusions, which I know has been it's a huge debate in our field right now. And we are all leaning towards kind of delaying and waiting and doing one definitive fusion. But how has that information changed the way you think about these kids in your practice?
Yeah, I would say it has been a definite evolution for me as well. I've been, working in this space for about 20 years now. And I think in the 2000s when, Vector came and then there was like growth friendly surgery and this whole new concept of thoracic insufficiency syndrome kind of caught our eye in the early 2000s. I think we were all trying to intervene early to prevent thoracic insufficiency. And then the magic rod came on the scene in 2014. And we thought, oh, great, this is a tool we can use to grow the spine, improve lung function, but they won't have to have nearly as many anesthetics. And now we're over 10 years into that. So I think it just took us time to get all the data. But basically now I do try to wait to operate. I mean, obviously there are certain patients where you're in a corner, like they're 5, they have 120 degrees of scoliosis and 100 degrees of kyphosis.
Yeah.
Obviously that is not someone you can totally ride out. There are techniques like you could probably put them into what I call forever halos. So you put them into halo gravity traction and they live in halo gravity traction for years. I have one patient who's been in halo gravity traction for 13 years. And you don't put any implants in their spine. And then maybe you could try to get them to a more, I'll say, skeletally mature state before you do one and done. But sometimes you can't. And then you just do your best. But in the other patients, let's say you have patients that are hanging out like in the 60s to 80s, maybe that's someone you can serially cast and get their curve down into the 40s, and then you brace for a while, and then it creeps back up, and then you cast again. And then, you try to get them to at least age 10 or something before you do surgery. I think all of us who do a lot of early onset scoliosis surgery know the earlier you put metal into a child, the more likely you are going to have complications. And now with this data, it seems they may not have pulmonary function that is as good as patients who were able to wait and get a definitive fusion and just a one and done, or anterior posterior spinal fusion at 10 or older. So I think it is a pendulum swing. We're swinging back towards trying to delay to have surgery, the first surgery happen as late as you can possibly have it be. But every case is, different. You have to do what's right for the patient.
Absolutely. I think that really what you just said sums up kind of your paper, or summarizes it in terms of just, we probably should be waiting as long as possible, which is appropriate for the patient. And then one other thing I wanted to bring up was that you did your multi-regression analysis and found that the idiopathic diagnosis was not associated with the poor outcome. I mean, I guess it would kind of be expected, but were you expecting to see that with that regression analysis, or was it
I
kind of
was. I
okay?
think honestly, I was saying when I got asked that on the podium as well. I mean, obviously, the idiopathic patients are the ones that have the least number of medical comorbidities. Um, So they're probably, and they're our most homogeneous patient, right? Like they're the ones that are the easiest to study because they don't have all the medical comorbidities that bring bias in. So if I always, so my take home is if you are going to do early onset scoliosis surgery, the patient who probably has the most to benefit are the patients that have idiopathic infantile or juvenile scoliosis. But they're also like the least number of patients, at least that I see. I
Yeah.
mean, I don't have idiopathics walking in my door, 10 a clinic. I have like maybe one every couple months, where I will have sometimes 10 neuromuscular and syndromic early onset scoliosis patients in one clinic in one day. There's just so many more diagnoses that give you early onset scoliosis if you have neuromuscular and syndromic conditions driving it. The spine is just another consequence of their disease. It's just another end organ system, just like respiratory, GI, neuro with seizures or tone. It's just another symptom of their disease. And I said, if we as surgeons think that putting metal in a child's spine is going to change the underlying disease that's causing the spinal deformity, we're just, I think, mistaken. Um, so
Yeah.
we're just treating another symptom of their disease. We're not curing their disease. And there's so many other things that affect pulmonary function other than the spine and the chest wall.
Yeah, and I think it's really hard to tease out how much of the decline is due just to their pulmonary function versus the spine and the curve, right?
Yeah, it all goes together, right? Like as they get older and they're, the consequences of their disease change, obviously the spine deformity worsens as well.
Yeah.
I
It's
know.
all intertwined.
It's very complicated.
Yeah,
And then those are the kids that are the hardest kids to get pulmonary function tests on as well, right? Because they
yes.
may not be able to, perform a pulmonary function test.
Yeah.
So then we're looking at other ways to try to determine pulmonary function that may not include a formal pulmonary function test, like maybe a 6-minute push test, a 6-minute walk test. There's other ways to look at breathing that don't involve, like full effort. It's just like how they breathe at rest. I think there's a lot of research that's going to be done in the next 10 years to try to like tease this out even more.
Excellent. Well, do you have anything that you want to say to wrap up?
Oh, I mean, I don't want this paper to be too disappointing for people. I do think, surgical intervention for early onset scoliosis has many benefits. I think we just have to have reasonable expectations of its effect on pulmonary function, because we talked about there's so many other things that affect lung function. And I do think we all need to start thinking about controlling that. If you are going to operate before the age of 10 and you can't do definitive fusion, then maybe think about ways to control that apex, because I do think personally apical control is going to make the most difference in lung function down the road.
Awesome. Well, thank you so much for sharing your insights into your paper and all of your awesome work down there. And have a great day. We appreciate it.
Thanks again for having me. I appreciate your time. And hopefully, if more people, this is my last, I'll say, soapbox, just collecting pulmonary function. If you can get your institution to collect pulmonary function, I think it's going to be, a super important data point for us all to investigate, because just looking at radiographs sometimes isn't the whole story. And I think if you can get pulmonary function in your clinic or your system, it's great. So please collect as much data as possible.
Great. Thank you very much.
Okay. Have a great day.
Too. Well, that wraps up our interviews with our exceptional SRS Annual Meeting Award winners. I want to congratulate the 4 of you again on your outstanding work and presentations. Thank you also to our audience for joining us today to listen to the Scoliosis Dialogues, the official podcast of the Scoliosis Research Society.